Okay, welcome to Chapter 4 of the 2021 book. So, I am going to talk about the revenue cycle management, different things the chapter outline. We will go through those. The objectives, I'm not going to read through each one, but you do have them. The introduction, we're really going to kind of go with the revenue cycle and talk about electronic data interchange. So, revenue cycle management. The process by which healthcare facilities and providers ensure financial viability. So we have quarterly provider updates from government programs. Again, your government programs are going to be Medicare, Medicaid, TRICARE, which is going to go in more with the military, utilization management, case management, revenue cycle monitoring and auditing, and resource allocation and data analytics. All right, let's just talk here with that revenue cycle. What all happens? So first of all, whether the patient comes in to the office or possibly to a hospital, it's pretty much the same. So the patient comes in, the physician does the ordering, the patient registers, okay? And at that point, we have a charge capture. Okay. So with that, the physician, the charge capture is going to be possibly the office call, a certain amount, or if it's the hospital, what are they being admitted for? Okay. So then we have diagnosis and procedure coding and auditing. So with that, with the documentation, the diagnosis is going to be coded, procedure is going to be coded, and then after that's all into the system, which we get into chapter 11, the patient discharge processing. Okay, so the patient is discharged. So with that discharge, we have a couple of things that have happened here. We have documentation from that patient visit, which is going to tell us what level of service happened, and it's also going to tell us what they came in for. Okay, so once that all gets done, it's going to go to our billing and claims, and they're going to process it. Then they're going to submit that claim to the third-party reimbursement, which could be Blue Cross Blue Shield, HMO, anything in between there. Now, if there would be something possibly wrong with, the claim where Medicare denies it or Blue Cross Blue Shield denies it, this will then go into the appeals process. They're going to appeal that claim saying this is incorrect. How can you fix it? So sometimes this process may be skipped. Then we're going to go to patient billing. So whatever the insurance company pays, usually unless it's 100% no deductible, the patient's going to get billed for some of that. Okay, then self-pay reimbursement posting, what the patient sends in, or possibly what the insurance company pay is going to be paying that amount. And if it doesn't get paid, if that patient doesn't pay what they owe, it could get sent to collections. And then hopefully at that point, collections gets the money from the patient so we can wrap up the whole cycle. Okay, encounter form and charge master. So financial source documents, we have an encounter form, which is also called a super bill. You do not see, I'm going to go right here to the super bill or encounter form. You don't see these very often anymore. Just because everything's done electronic. This used to be a super bill back in the day, and with it, they have diagnosis codes on it, office visit levels, if there was any procedures, injections, the patient's name, insurance company, all this was on an encounter form. And what would happen, they would take the information from the encounter form and put it onto a form that would get sent to the insurance company, which would be the CMS 1500. Okay, so let's talk about the charge master. It's also called a charge description master, but the charge master it keeps track of all different procedure codes. So if a patient comes into the doctor's office and is seen for just a visit, evaluation management code, which we will learn about too, but just to get the idea, the patient is seen. Whatever they are seen for, they put that code into the system. There's already a charge in there for that code. That's called a charge master. Patient comes in for a chest x-ray. That chest x-ray code is in the charge master, right? So with the charge master, it's going to get updated maintenance once a year. So if there's a change in a code, charge master, whoever's maintaining it, or the team will change that code and possibly change the amount. Everybody knows each year things go up in price. So that code for a chest x-ray that could have been $170 in 2023, it now could be $190. Depends what the increase was. Talked about the encounter form. This is kind of what a charge master looks like. So here, a service code, and this is what I was talking about, those CPT codes. So they're already in the system. So here we have a chest x-ray single view, and that's the charge for it. Now, as you can see, a chest x-ray with 2 views, different CPT code, but it's going to cost a little bit more money. So every code here, every CPT code has a charge to it, okay? Processing an insurance claim. This used to report professional and technical services. Information from the encounter form or charge master is transferred to CMS 1500 or UB 04. We'll talk about this more in Chapter 11. So in Chapter 11, we talk about each of these forms. CMS 1500 is for the physician to get billed, okay, for the physician actually to get paid. And the UB 04 is for the hospital to get paid. So they take the CPT code here and they put it onto the CMS 1500. So this is how it all starts into the revenue cycle. All right, so this is what our CMS 1500 for claim form looks like. And our CPT codes, we have all the information up here, the type of insurance, patient's name, their insurance company, accept assignment, all of that. Okay, managing patients, new patients and established patients. So we have par versus non-par. Okay, we have primary insurance versus secondary insurance, birthday rule, gender rule. So let's start here with new patients and established patients. New patients is somebody who comes in. Let's go ahead and look at this in your book. Look up the definition of new patient. A new patient is one who has not received any professional services from the physician or from another physician of the same specialty, belongs to the same group practice within the past 3 years. I'll talk about this. Where an established patient is one who has not received professional services from the physician or from another physician of the same specialty who belongs to the same group practice within the past 3 years. All right, so an established is one who has received. I'm sorry if I said has not. Establishes has received. Okay, so with the new patient, we have a 3-year rule. And let's just talk about this. I'm going to go ahead and say medical associates. So with medical associates, let's say I am new to internal medicine. I'm going in because I have high blood pressure and I just want to see the doctor, have the doctor follow me up on my blood pressure. So I go to that doctor, charges a new patient. 3 months later, they want to recheck, but my original doctor, Dr. Smith, isn't there. So I'm seeing Dr. Jones. All right. So Dr. Jones, even though he's a different doctor, he's still at Medical Associates and he still is internal medicine. So it's 2 different doctors. Now I'm established. Okay. So I'm an established patient within internal medicine. So now let's say that I have been having really, really bad headaches, really bad headaches. So I'm going to go to neurology at Medical Associates. So I go to neurology and Since I am new to neurology, they can charge me as a new patient. Even though, let's say, I just saw my internal medicine doctor at Medical Associates 4 months ago, that 3 windows there doesn't matter. Neurology has to do a new history on me. I'm going to have they're going to look at a different history just because of the headaches. Okay. They're going to have to do exam that goes with neurology. So they can go ahead and charge for a new patient workup. Okay, so now let's say I wasn't very happy with them and I go to Iowa City, I go to the neurology department in Iowa City. They can also, since it's not the same facility, they can also charge new patient. All right. So it's a 3 years, but it has to be, again, with that specialty. So even if I flip flop different, if I go to Unity Point, Mercy, those are two different areas. And, within Unity Point, we have their doctors there also. So again, new to the specialty, not so much to the clinic. So primary insurance versus, let's go with par versus non-par. So with par, that means they accept insurance. Where non-par, they don't. So what that means is par, they're going to accept whatever the insurance company pays them. Keep in mind, you're still going to have to pay for your copay and you're going to have to pay for your deductible. But that means if your insurance company states, we're going to write off a certain amount of money, you are not responsible for whatever they write off. Now, if they are non-par, that means you are going to be in charge of paying that extra money. So let's say par, okay, it's $100 and your par insurance, you're going to Medical Associates and they accept Blue Cross Blue Shield, okay? So with that, with par, means they accept it. So they charge you $100, Medical Associates does. But Blue Cross Blue Shield says, you know what? We think only $90 should be charged. So that means Medical Associates has to write off that $10. You do not have to pay that $10. You will have to pay, if you have a 90, whatever your deductible is, but you will be responsible for that $90. That $90 could be possibly, you only have to pay 20% of it. You may only have a $20 copay. Now, if it was non-par, you would have to pay your copay plus that $10 they wrote off. So keep that in mind. So the big difference between these two also is if they are accepting insurance, that means that Medical Associates get the money directly from the insurance company. Okay, they may not be able to charge the whole $90, but they're going to get or the whole $100, but they're going to get $90 right away from the insurance company. They're non-par, the insurance company pays the patient. They pay the patient. So that means that $90 went to the patient, and now you have to collect that $90 plus the $10 they also owe your facility. Okay? So primary insurance versus secondary insurance. They always go by the birthday rule and gender rule. Let's start here. Primary insurance, let's say I carry it, which I do for the dental. Okay? It doesn't matter. So primary insurance is the dental, and my husband has dental. We both carry dental insurance. It goes to the insurance with the birthday rule. My birthday is in February, his is in March. So it's going to go to my insurance first. And then it will go to whatever my insurance didn't pay, the secondary insurance. Okay, managing office insurance finances. You want to select ICD-10 CPT HCPCS code using Encounter Form or Chargemaster. You want to post those charges in patient account record or patient ledger. Make sure you complete the CMS 1500 and claims form. And then you want to log completed claims and insurance registry. You're going to submit that claims form to the clearinghouse, third party payer. Keep in mind, This is all covered in great detail in Chapter 11. It's patient accounts, the ledger. Okay, so here let's just say the invoice was $260. That's what they charged for code 99214. That's the balance. So let's look here. If the patient had a $20 copayment, okay? So now it's down, they owe $240. That's credit there yet. Okay, so the other thing is, so that's all paid off. Now here's a different invoice. Charges were $190. Copayment was $20. And then they came in and paid $170. So zero balance on each time. This is all because of the copayment. If there wasn't a copayment, it was deductible, this could be a little different. Sample day sheet. Once again, this just shows you the charge. If they adjusted any off, because let's say they weren't par, they did not accept assignment, or they did accept assignment, so they're writing $20 off. These are just different patients. Here again, you can see the different adjustments that they made. And here we have Timothy Taylor. They charged him $90. They didn't adjust anything off. So this could possibly be non-par. They are not accepting assignment. It's non-par. They did not adjust anything off. For all these other charges, they adjusted amount off. So what's going to happen here, Timothy Taylor will be responsible for that whole $90. Okay? The insurance company must not have paid anything on this. Sample insurance claims registry just shows you the insurance company, the amount due. Okay, the insurance claims cycle. Let's talk about electronic data interchange, computer to computer transfer of data between the provider and payer or provider and clearinghouse. Claims processing, we do payment of claims. So here you can see we have the submission of the claim. It's going to process, adjudication right here, and then what that equals to is payment. That's a flat file for any of you who are into computers. I won't have to worry too much about that, just so you know. So covered entities, these are required to use standards when conducting defined transaction covered by HIPAA. So these are, again, these are all under HIPAA, confidentiality. Who is all covered under HIPAA? We have healthcare clearinghouses, all right? And I talk about this in Chapter 11. After those claims get done, let's say at a physician's office, they all go into a clearinghouse and they wait there. Okay? Sometimes the clearinghouse is going to scrub them. And what I mean by scrub, just like anything, if there's anything dirty in those claims, codes that are wrong, or if a code is for a female but listed as a male patient, they're going to scrub, and those are actually going to come back then before they go out to the insurance company. So they wait into the clearinghouse at a physician's office, and let's say on Saturday, that clearinghouse releases all those claims to Blue Cross Blue Shield, Medicare, Medicaid, TRICARE, HMOs, okay? They distribute them. At covered entities, Medicare, Medicaid, they are also covered. And we also have plans for retiree, military health system, Indian Health Service, people who submit or receive transactions electronically, workers' comp, TRICARE, CHAMP, VA, managed care plans, and then your commercial health plans. These are all covered, again, by HIPAA. All right, so these are review of claims, and this is, again, covered in Chapter 11. So you put down the identification number, who's the payer, what their ID number is, names. All of this goes into smaller down here. Who's relationship to the insured? So if I carry the insurance, it's going to be self. If I have a child that goes, it'll be child. And then female, you put all that information in. Claims, adjudication, and payment. This here, you have your clearinghouse. The payer performs claims validation. like I always call it scrubbing. And then it either the payer approves a claim for payment, payer denies it, then it comes back. The payer rejects it. That means they can resubmit. Okay, they can resubmit. Here, usually, the payer denies a claim, but they just need some more information. This, the payer rejects, saying, nope, the insurance company doesn't pay this. So at that point, then maybe they can, if the documentation allows them to get a code that possibly could be paid that isn't fraudulent. Okay, so we have a sample remittance advice. Here we have just different things. It's what is allowable. So data services, paid 200. So here we didn't have anything. Allowable is 100. They had a $100 deductible. Okay. With that $100 deductible, it means that they will start paying as soon as the deductible is met. Okay. Explanation of benefits. This actually tells, this comes from your insurance company. I get one from Blue Cross Blue Shield all the time. And what they do, let's kind of look at here. It's Blue Cross Blue Shield. Will give me the name, data service, the amount charged, and then remember how I talked about the amount allowed. So here it looks like this insurance company is allowing everything. And the copay, the deductible, what the patient, again, is responsible for. And then the plan benefits. And it'll just say how much they paid. And then right here, this is not a bill. This is just explaining, explanation of benefits, what is allowed. And then if you do have a deductible, a lot of times it'll tell you what you have left of the deductible. So maintaining insurance files. You have all these different things. You have source document, open and closed, unassigned claims, remittance advice documents. You have denied claims or unpaid claims, remittance advice, denied claims in the appeals process. Then we get into the collection. So routinely collecting payments at the time of services are provided. You want to implement these inconsistent credit and collection practices. So it kind of depends. A lot of your physician facilities will have their own collection agency take over on bills that haven't been paid. All right, then we get into aging reports. These are claims that are out there that possibly they're outstanding, where maybe they're waiting on the insurance company to process the claim again or waiting on documentation. They rejected the claim. They're waiting to submit a new RA, remittance advice, like we talked about. So this would be, again, looking at an aging report. Now, keep in mind, a lot of you won't do this being a medical assistant, okay? You are going to be more for patient care. It's just good that all of you have a background and an understanding what some of this is. So if you have any questions, please let me know.